Welcome. My name is Steve Slade. I'm the Director of Research at the College of Family Physicians of Canada. Thank you so much for joining us on a Friday afternoon to talk about data. So I want to first of all acknowledge the lands that I'm dialing in from. I'm in Ottawa, Canada, the traditional lands of Algonquin people and Anishinaabe people, and so very pleased to be able to join you from here. Just to sort of recognize the importance of Indigenous peoples. I'm sitting here in Ottawa and we are breathing smoke like crazy. We have much to thank for our Indigenous peoples in terms of maintaining and stewarding the land and taking care of the land. And I think we are so reminded of that right now across Canada. We're experiencing global changes that are affecting our environment, and it's a moment of reflection. We're going to be talking as well about data today and what we are hearing from family medicine residents and early career family physicians. One of the things that we are very clearly seeing in our data is that family medicine residents, when they complete their training, they feel that they could have been more immersed in Indigenous health. It's an area that we need to continue to pay attention to. When we look at family physicians in their early practice, there's a disconnect between what their expectations were in terms of providing an Indigenous health and actually doing that in practice later on. And so it's another area where we can look at Indigenous peoples in Canada. So I'm going to introduce our panelists in a moment here, but I just want to give a quick introduction to what is the FMLS. I'm not sure where people are at in terms of knowing what the Family Medicine Longitudinal Survey is, but this is the data source that we're going to focus on today in this first webinar of health data, and particularly data that relates to family medicine training, evaluating it, looking at the outcomes of it. So the Family Medicine Longitudinal Survey has been running since the inception of and the ramp up to the CCFP curriculum. For those who have been around in our milieu for a while, you know that coming up to almost 10 years ago, the CFPC led a fairly large pedagogical change related to the CCFP curriculum, a new way of looking at and sort of entrenching family medicine training in the discipline of family medicine. And at that time, we wanted to ensure that we had systems in place to look at the impact of that change. And that is what the Family Medicine Longitudinal Survey is all about. As changes were being made, how are we measuring the impact at the end of residency training and into practice? And of course, as a baseline measure, what was on the minds of family medicine residents as they were entering their training program. So we, through the Family Medicine Longitudinal Survey, we survey all family medicine residents as they enter their program, as they exit their training, and 3 years into practice. The Family Medicine Longitudinal, the survey itself, and as you can imagine, we have very high response rates for time 1 and time 2, that as you enter and as you exit residency training. Family medicine residents are there, and we get typically sort of 50 to 60% response rates, and at times higher, and with some schools higher. We are asking about the demographics of residents. We are asking them when they are exiting their programs, what were their learning experiences? What areas of practice did they feel that they received adequate exposures to, and they're feeling confident about the education that they receive. We ask them about their perspectives of the discipline of family medicine. What do they think about their own professional identity as a family physician, and how they feel family physicians are valued in society, the role that family physicians play in society. The survey asks about this. Importantly, at time 2, as family medicine residents complete their training, we ask them, what are their intentions of practice? What do they think they'll be doing when they go into practice 5 years from now? And we may see some of that today. Certainly happy to talk about it with you more. And then we, of course, we survey family physicians again when they are 3 years into their practice, and so we can see how did those plans actually pan out. So that's the kind of data and information that the survey gathers. We do this. The reason that we do this again is to look at the impacts of training. We do it for the purposes of program development, research and quality improvement, program evaluation. We hope that it is informative to departments of family medicine as they think about their own curricula and the review committees that are in place to look at how they would tweak their curricula. It is at times used for the purposes of accreditation. Departments of family medicine look at this survey data, and it may come forward when they are going through processes of accreditation. The CFPC looks at it for our own program development and the ways in which we to support departments of family medicine. So it's both a policy development resource, data and evidence for policy development at the CFPC, as well as our advocacy work. We use this data to talk about the things that family physicians do in society. So I just wanted to give a very quick introduction to what the FMLS is. You'll get a better sense of it through the presentations today. And when we turn to questions, we certainly would welcome questions about it. Last thing I'll say about the FMLS, in case it doesn't get said by anybody else today, and at the prompting of my colleague Laura Leidnardi, who is the manager of the Education and Evaluation Research Unit that works with the team, I want to note Noor and Masa and Dragon, all of whom are here with us today and are instrumental in the delivery of this Family Medicine Longitudinal Survey, working with departments of family medicine. If you have any connection to people that would answer this survey, whether they are coming into their residency training or they are exiting their training, or they're into practice already and they might be invited to answer the surveys, please, if you could do anything to sort of encourage them. The information is valuable in so many ways. Our panelists. So I'm very pleased to introduce Dr. Lisa Graves, who is a family physician and a professor in the Department of Family and Community Medicine at Western University, the Homer Stryker MD School of Medicine in Kalamazoo, Michigan. Dr. Mahan Kulasegaram is a scientist at the Wilson Center and Temerity Faculty of Medicine at University of Toronto. He is also associate professor and director of the Office of Education Scholarship in the Department of Family and Community Medicine at U of T. And finally, Dr. Milena Forte, also a staff physician, family physician at Mount Sinai Hospital in Toronto. She is a clinician educator and associate professor in the Department of Family and Community Medicine at U of T, where she leads the maternity care program and is the postgraduate lead in the Office of Education Scholarship. So we're going to turn it over to Drs. Graves, Kulasegaram, and Forte to present some of the work that they've done using the FMLS. I think I'm going first to you, Lisa, please.
That's right. So the way that we have decided to structure this time together is I'm going to provide you a little bit of an overview of a sliver of what we've been doing as a group. Milena is going to speak a little bit about the use of school-specific data, and Mahan is going to keep me honest in terms of the things that I want statistics to do and the things he tells me that statistics cannot do. We've entitled this, we've left lots of time for questions, comments, etc. This is very much still a work in progress, and we wanted to make certain that we acknowledge the assistance of our collaborators in this project, and Ivy and Suda, who are named below. We've entitled this Data, and More Data, Experience Working with the FMLS. And I think one of the things that was, for me, one of the most exciting parts of working with the FMLS is that when a lot of us who sit in the educational research space start thinking about what questions do we want to answer, how do we want to answer them, we get very excited if we have a study subset that has 50 people in it, 100 people in it, 200. To have the numbers that we have with the FMLS is really quite exciting. Something that our clinical colleagues don't get as excited about, because for clinical colleagues, this size of data set is not as completely unusual. But for those of us who are used to smaller data sets, we were really excited about the fact we had lots of data. Lots of data also presents lots of challenges, and we'll get to that. So what we really wanted to make certain we talked about today was really sort of what was sort of a kind of a team approach for looking at this data, and also to talk about some of the challenges and opportunities that working with this larger data set presented, with the hope that others will consider doing similar work. So thank you, Steve, for that wonderful description of the Family Medicine Longitudinal Survey. We weren't certain if someone was going to cover that, and I wasn't certain. I had hoped that everyone in the audience might be aware of it, but I'm also aware that sometimes there are gaps. The way that we sort of saw the value of the longitudinal survey was it provides a trajectory of family medicine residents, kind of from the start to sort of residency to that period post-residency. And so we were really interested in that longitudinal approach. What we really liked as well was the exploring of intentions. And because we were going to be focusing on maternity care in particular, the intention to do maternity care is something that we've all been interested in for some time. And we like the idea that by having some data on graduated physicians, and by graduated physicians, I mean graduated from their residency program, it kind of allowed that comparison between what did I say I was going to do and then what actually happened. In terms of the maternity care piece specifically as it applied to the longitudinal survey, the CFPC professional profile still requires that family medicine residents graduate from their programs with competence in full scope maternity care. And that's an important parameter for understanding that given the places where family medicine residents end up, that the ability to provide prenatal, intrapartum, and postpartum maternity care upon graduation, the ability to do that has important implications for Canadian families in terms of being able to deliver maternity care in a variety of different settings to a variety of different patient groups. Over the years, if you've sort of been following the thinking around family medicine maternity care, or FMOB, as we sometimes call it, there was for some time a real focus on that number had been decreasing. And there was a concern that that number would decrease and would gradually fade. What we were starting to notice is that it had hit sort of a low and was starting to bounce back. And so in the context of being very concerned about whether or not family physicians were going to be able to continue to meet the needs of Canadian families in terms of providing that full scope prenatal, intrapartum, and postpartum maternity care, there'd been a lot of work that had been done in sort of the last 15 to 20 years, looking at how to stop that decline and, if possible, start it back to increase. So there's been a tremendous deployment of educational and clinical resources to look at how we can continue to develop confidence and competence to deliver maternity care so that graduates of family medicine residency programs were actually feeling that they were well trained to do this work. I think that virtually all of us who are involved in this project had at some point been part of a paper or a guideline or a thinking group or something that talked about sort of, what it was that needed to be done. And what I wanted to do was sort of talk a little bit about sort of what was sort of happening in the background. Early work looking at the decline decline in numbers of family physicians providing maternity care emphasized the importance of role modeling, being able for residents to be able to see themselves in practicing physicians who included maternity care as part of their practice. That teaching of emergency obstetrical care was actually critical in maintaining that comfort, confidence, and willingness to practice. And from that work came courses like the Also an Alarm course, Advanced Life Support in Obstetrics, and also the Advances in Labor and Risk Management courses that really fueled this, this addressing of emergency obstetrical care, a feeling of comfort, not say comfort, because emergency is never comfortable, but a confidence in the ability to handle obstetrical care. And that really creating a faculty, particularly family medicine faculty who had obstetrically competent, were really parts of key components of success in the early work that looked at this. And this early work came from, in particular, work done in both Canada and the US. Specifically in the Canadian context, success became linked with, again, appropriate clinical exposure, family medicine role models, a family medicine friendly inpatient environment, so a labor and delivery or birthing unit that was supportive of family medicine obstetrics, and broader support of maternity care education as well, from including the non-maternity care family medicine community. And again, a supportive community of family physicians who provided maternity care. There also has been a significant increase in the number of opportunities for enhanced skills training in maternity care. And that part of that expansion was also filling some of the gaps that were existing between the residency completion and full movement into unsupervised practice. And so that was sort of the background that sort of we were thinking of and had in our minds when we started to think about what the longitudinal survey could tell us, because we wanted to know the trajectory, and that lines up with what the FMLS can tell me. So what's the trajectory of residents' consideration, thinking about maternity care over the course of their residency, on entry into residency and into early practice? And then what were the factors that we might be able to provide residency programs so they can know where in this next phase of targeting residents to encourage maternity care, where were some of the areas where a focus of energy and effort was likely to be successful. So in my very simplistic brain, the way that I looked at the data was saying we have kind of on entry to residency, we have during residency, and we have what happens after residency. And what as a team we were curious about was, what have we done? And this reflects my deep passion for the importance of training our undergraduate medical students. What were we doing before our residents came into our residency that might be helping or hindering what it was that we were hoping to achieve, looking at this through the maternity care lens? So did they enter our residency having had exposure to family medicine obstetrics? During residency, once we had them in the door, did we do something to them in residency that made them more or less likely to consider including maternity care as part of their practice? And finally, if we got them through residency, was there anything that was happening to them after the completion of residency that looked like it was having an impact on intention to provide maternity care? So what do they look like when they started? What did they look like? What do we do to them when they were in the middle of their residencies? And then what were we doing to our residents when they left residency? And that was my very simplistic hope of what we were hoping to get from the data. So we used a number of models, looking at Likert scales, linear regression on intention to practice. Some of the data was linked, some of the data was not linked. We tried to create a model that would sort of tell us what some of the predictors were, and also to look at just some basic descriptive statistics that could describe what it was that was happening and whether or not those things that were happening were significant. So I'm going to share some, but not all of the results. We looked at a cohort entering family medicine training from 2014 to 2018. T1 data, so that entry data was available for all cohorts. T2 data was only available from 2014 to 2017, and the T3 data, we were able to get it for the 2014 and 2015 entry cohorts. And some of these, and you can see the numbers of the data were large, and it was very exciting for me to see a large data set. Matching between the T1 and T2 cohorts was not always possible. And that was something that we had to be accounted for in looking at the results and the statistical analysis. And data was available for 649 respondents for the T3 data, some of which we could link back to T2, but some of which could not be linked back. And again, 649 in comparison to 4,893 doesn't seem like a lot, but again, based on some of the size of some of the data that one works at looking at medical education, it was still a really fantastically sized data set. We did look at the predictor variables that were sort of determined and in place with the as part of what was the defined already by the Family Medicine Longitudinal Study, and kind of, they lump themselves itself very nicely into the actual characteristics of the residents' experience, intention to treat, attention for future practice, intention for clinical work, and then educational exposure. And obviously, some of these predictor variables are things that we can change, and obviously some of those predictor variables are things that are not changeable. And we were interested in seeing if, in particular, if some of the predictor variables that were under our potential influence were actually significant. So again, not surprisingly, residents identifying as women were more likely to indicate intention to practice for maternity care at T1 and T2. International medical graduates, more likely compared to Canadian medical graduates. Married residents, higher intention. Those planning on practicing in a group, higher intention. Teaching practices, again, not surprisingly, higher intention. Comprehensive care across multiple settings or with a special interest in maternity care, obviously, again, not surprising. A specific interest in a focused practice was again not surprisingly showed a less likelihood of providing intrapartum care. They were relatively consistent between T1 and T2, which again is somewhat reassuring. And from that, if you think about that one question, are we doing anything during residency that might be impacting on a resident's intention to practice maternity care? So that consistency was somewhat reassuring. The other thing that was reassuring was that a significant predictor, and one that accounted for the largest effect in T1 and T2, was exposure to interpartum care during training. And again, having, as a group, many of us worked in this space about, how can we improve the educational experience? This suggests, and I'm carefully using the word suggests because I don't want, my team will tell you, I don't want to leap into things that the results are still pending on, but it suggests that the work that has been done to increase the educational experience related to maternity care has not gone to waste, that in fact that it is making a difference. And adequate exposure was certainly better, had higher intentions to treat than those who had some or no exposure. Pattern held at T1, which again, if you think about it, for me, T1 is measuring what our residents are coming into our programs about, which again suggests that that focus on exposing undergraduate medical students to the possibility of family medicine, maternity care, and maternity care in general was again, the work that was being done there was again showing that it was likely to impact again on residents at entry, because that pattern continued to hold as residents moved into T2. This is just a picture of this, and again, this is all cohorts, and again, if you look at this again, the more and more of our residents are reporting that they've had adequate exposure to intrapartum care, which again, I think reflects a significant amount of work that's been done at various educational levels. This is a slide that, again, if sitting in that sort of literature space, intention to practice intrapartum care, T1 is sort of the light blue color, the bar that's in the front part of the cohort, and T2 is the second bar of each little cohort. And although the numbers are what they are, And there are drops. What again was incredibly reassuring that the drop off between T1 and T2 that used to feel fairly precipitous is in fact relatively small. So the fact that close to 18% of T2 end of residency survey completers, that there was reporting of an intent, highly likely to provide intrapartum care, suggests that sense that the curve has reached its bottom and is turning up is actually being reflected in this chart. Clearly, something happens during residency where there are decisions that are made that, you know, I'm going to do or not do family medicine residency, family medicine intrapartum obstetrics. But again, the less precipitous drop, particularly amongst the highly likely group, again, was data that we'd like to interpret optimistically. T3, again, smaller subset, but of this group, 31% were indicating that they were providing intrapartum care. And there are all sorts of limitations we can think about whether they, you know, family medicine accoucheurs are more likely to complete FMLS surveys. I can't really comment on that. But again, of our responders, 31% indicated they provided intrapartum care. And when you sort of looked at the cohort we could match, that group, 62% indicated they were providing intrapartum care at T3. So again, that's, although there is a drop, it's not, again, the type of precipitous drop that we had been worried was actually happening in family medicine obstetrics. Few lessons learned. It can provide insights, but must be interpreted cautiously. And it's one of, I think, the best reasons to have a team approach to looking at this data, because when I get overly optimistic about how I'd like to interpret the data, my teammates remind me of, again, the limitations and concerns about the data. But certainly the trends that we're seeing from looking at the FMLS and digging deeply into the data suggests that there has been improvement, and there has been improvement in areas over which residency programs have had some control. Obviously, there are changes in response rate over time, as we noticed with the drop-off with T3 respondents. And there is a variable response rate between institutions that, again, may present challenges if large programs with high response rates are included as part of the data set. The other challenge is that the FMLS was not designed to it was not designed to provide the answer for maternity care interested folks about whether or not it was not aligned with our very specific purpose. But again, what we have found is that the education evaluation questions that we wanted to ask, and some of the particularly broad strokes we wanted to see reflected in a national effort, were actually there and allowed us to, and is allowing us, we think, to make some statements about where Canadian family medicine maternity care education is, and what efforts are needed to continue to sustain those efforts, as well as areas where we have control and may be able to change some of the predictors. I wanted to take a minute to first of all ask Mahan for any comments related to our statistical thinking, and also again, Milena has some very specific experience using program and school specific data that I thought would be of interest. And since this slide is not very interesting and my next slide says any questions, I would like to stop sharing the screen so I can actually see people's faces, if that's all right with everyone. So Mahan, I think I'll toss to you to mitigate the enthusiasm that I have with a better understanding with any comments around the statistics, because I think that's one of the challenges of this data set is some of the messiness of it has presented challenges to the team, challenges that are overcomable, but have been challenges.
No, Risa, I think you did a fantastic job of explaining all of the statistical concepts. I think one of the things to point out is that we were able to identify predictors that were in sort of various categories and sort of build a sort of final model that can give us an indication of people's intention to practice at each stage. And the work that I think that still needs to be done perhaps is to sort of validate that model as we move forward with more data collection in T3 and sort of linking that data from T1 to T2. And then the other piece to say is that, overall, the quality of the model, the predictors might sometimes can be quite powerful compared to, one another. But overall, the model itself didn't explain a ton of variability. So it provides insights, but it's not a complete picture of how people make these types of decisions. And as I think we're finding out with other sort of discussions and changes around the family medicine curriculum, people's intentions to practice versus their actual decisions about practice are influenced by a host of factors, some of which the FMLS captures very well, and others which are captured through other data sources or really idiosyncratic and, we could say contextual. And so I think what the advantage of doing an analysis like this, though, is that it really crystallizes for a residency program, either at a national level or at a local level, what factors can we actually manipulate and support or adjust, and what can we know about our residents at least that help us in sort of targeting training appropriately if we think of that goal of having comprehensive care and interpartum care. Robert has asked a question: is there a lot of variability according to jurisdiction or province? And Helen has asked if you mentioned this already, sort of about accessing the years of collection. So maybe I'll start with Robert around this question. So we looked at we have the data in a very secure fashion, or a process of access that Laura Lee and Steve and Dragan can sort of explain, means that we don't have a lot of information that could potentially de-identify the resident or the program they come from. So what we have in our data set is essentially a numeric code for the program. And actually, you can't even use the number or the size of each program's sort of code to de-identify the program, because response rates tend to be so variable. So it really is a data set that protects the institution that the residents coming from, which is really important. So based on that, we can't really do a ton of inference back to an institution, but we can say, what is the effect of institution contributions to intention to practice, and they tend to be quite small, which is really surprising for us, both the medical school and the residency program, as well as the cohort of data collection. We didn't look at the data by province, but there is a regional collapsing of the data set, so that, if there's a single institution that does family medicine training, obviously it'd be very easy to de-identify that institution. So there is some aggregation: Ontario, Quebec, I think Western Canada, and so we have got that. And that did have a little bit more power in explaining, but it's very difficult to interpret, or at least it must be interpreted with a lot of caution, because you can't tie it back to any one thing or any one province.
We can come back to that question as well, Mahan, afterwards, but I don't want to cut off. I know that our panelists may wish to speak more, but we can come back to the important questions that are coming up in the chat as well.
I was going to Steve to toss the baton to Milena, and I also think that what Milena will speak to may actually answer one of the questions about sort of taking there's the big data set, but there's also other things that can be done with this information. And I'm going to toss over to Milena to talk a little bit about her experience with that.
Absolutely. Thanks, Lisa and Mahan, for that great overview. So you can, for the audience, you can keep putting questions in the chat. You can also jump in. Maybe we'll give you an opportunity here shortly. I think some of the questions around the timing were addressed by Lorelei. So each site has the option of that 3-month window. So for instance, at our institution, we actually do T1 in September. So in fact, we are capturing a little bit of the residency experience. So with respect to our project of interest here around maternity care, it's quite possible that residents that had their obstetrical rotations or experiences in July and August would actually be reflecting that regarding their training and residency as opposed to med school. So just important, because that's a variable as well that we didn't actually, control for when we looked at the national set. We know it's a window of time. I think one thing that I just want to highlight that with this project, we were talking about the aggregate data, which is where you can get these, huge numbers, particularly over time. And in order to access, to access this data set, I think there was a question around resident projects. There is a formal process through the CFPC that Lorelei and Steve could probably speak to more clearly in the recent process. But yeah, I will say that the other really interesting way to look at the data is at other levels. So there's the aggregate data. Each school, and so typically the results will go to, in all of the Canadian Family Medicine training programs do participate. This was agreed several years ago. So each institution also has their site-specific, their institution-specific data. And that data is accessed in a different way because that goes to typically the principal investigator, as well as the chair and the program director. In some cases, those are the same people as the PI, in some cases not. It's not the case in our site. So if anyone locally wants to look at that data, for instance, in our institution, some of the leadership or exec in the postgraduate program would have access through us. And actually what's interesting about looking at your local data is that, first of all, you can compare it to the national data, and you can get that data either because the national data will have your institution as part of the aggregate, but you can actually request to deaggregate that data. It's probably more important for big programs like ours in Toronto because we make up about 10% of the data. So we can shift the data that way. But for other smaller programs, that might not even be necessary. So you can compare yourself to the national aggregate. You can compare yourself over time because the study's now been running long enough that even if you have a small program, your numbers actually do add up. For larger programs such as ours, the other interesting thing you can do is look at data by site. So if you're a distributed site, so we have 14 sites within U of T, over time, the first couple of years, those numbers per site were quite small in the sort of couple of dozen of students of residents per site. But over the years, they've actually become quite larger numbers. So you can actually, from a quality improvement perspective, start to look at, well, are there certain sites that, for instance, again, germane to our question, are there certain sites that consistently have much higher rates of residents wanting to do maternity care? What is it about those sites? Are people drawn to those sites because of certain factors? Are people being trained differently in those sites? So you can use the data in a variety of ways if you're creative, and not all of it is amenable to, for instance, scholarship and distribution, but some of it's got really local value that can be accessed in a much more informal way, often than look at the national data. But so I would just say levels of data and data over time can be quite powerful. Maybe we'll take some questions before, if people have questions around anything that's been presented so far. I can talk a bit more about the institutional data and some other work we've done, but I think there's enough questions to keep us busy for now.
Thanks, Milena. Thank you to all of our presenters. I think that's sort of where maybe at the end of the formal presentation and hoping to open it up here. We have had a couple of excellent questions in the chat there, but if people would like to raise a hand and ask questions of our presenters or make comments about what you've seen today, perhaps about the ways in which you've used data, the potential uses of this data, we'd be absolutely happy to have a kind of a free-flowing conversation here about that. If I could, I am wondering to our panelists and maybe to others who are, sort of within the milieu, how does I'm just wondering, how does the data sort of turn into changes within residency education? And I'm not judging it in any way. It could be that it's just sort of helpful to know and then it may permeate and affect sort of the thinking that in sort of unmeasured ways lead to changes sort of in curriculum, or are there more formal mechanisms that kind of where data is looked at and sort of formally considered as a part of curriculum review, curriculum renewal processes?
I can start us off and speak to that a little bit in our institution. So because this coincided with our accreditation and the ability to kind of collate the data, we were able to look at that. I mean, there's such a vast amount of data that you can look at. It's a matter of choosing what you want to think about. So right at the beginning of this presentation, Steve, you reminded us all how it's actually, it's a national result that our residents are telling us they're not getting enough exposure to Indigenous care. So that number one, which at U of T was part of data that led to, there were other reasons as well, but led to a real expansion of what we do in terms of Office of Indigenous Affairs and how we start to look at supplementing that curriculum, innovating, creating leads and et cetera, to try and really address that. The other just quick example I'll give is around procedural skill acquisition, which has consistently sort of shown up to be an area where people want more. We have data, we've been hearing this kind of informally for years, but we have data, particularly post-pandemic, I think really pointedly showing how people are less likely to do procedures in office practice if they don't get exposure, and the exposure dropped precipitously, particularly in the last 3 years. So those kinds of things can lead to programmatic change if it's a starting point for identification.
There's a question in the chat, which I think will be of interest, related to doing data analysis in a paired fashion. And Mahan, since you had to help us navigate that for our data set, I'm going to toss that question towards you about what can be paired and what can't be paired.
Well, you know what, Dragon might be better positioned to speak about some of this, but I'll just say that when we received the data, it was challenging, I think, to do a T1 to T2 linkage. But so that means that what we're doing and comparing the data, we're actually looking at cohorts that are technically not independent from one another, but we also don't know the degree to which people are likely to respond twice to the survey. But Dragon, I think you've made a lot of progress in recent years around that problem, and maybe others won't have that issue.
Yes, we managed initially to use our unique identifier to do the matching between T1 and T2 and T3, but we discovered a lot of errors that respondents are doing answering questions, especially the one in which we ask for last 3 letters of their first name. They often enter first 3 letters or last 3 letters of their last name, and almost 20% of them are doing it wrong. So that makes matching difficult, and especially because our initial unique identifier contains 9 different variables and each variable contributes to problems with matching. We reduced the number of variables that we use for matching, still using 3 letters, the first, then year of birth and the day of birth, and of course residency program, sex, and we managed to match around 50–60% of data, especially between T2 and T3. At this moment, we have last 4 cohorts of T3 matched with T2 data, which allows us now to look for predictors in T2 data that are good in predicting variables in T3.
I'll just add one other thing that is at a much more simplistic level, not as sophisticated as the response Dragon gave, but it's simply not, it's a voluntary survey. So it's possible if you have a 50% response rate that 50% of your R1s answered T1 at entry and the other 50% answered T2 at the end of graduation. So sometimes even with the best efforts to match, you actually have different people filling it out. So typically that's not quite the case, but that is an inherent built-in issue with voluntary surveys.
Which is why it's really important, I think, that programs do their best to support the response rate of their trainees. Milena's done a great job at our institution of really advocating for protected time so that the trainees have a chance to sit down and do it on like the end of their academic half day or something to complete the survey in a timely fashion. And I think similar best practices are something I know that EERU is developing for other programs that could sort of learn and benefit from that approach.
It's important also to have in mind that in T3 we have 20% response rate average, and in T2 it's around 50-60%. But still, we managed to match 60% of T3 responses with T2 responses.
The protected so just to address the response rate, if there's programs interested, I mean, it's quite simply just has come down to reminders, but it's really the protected time. So U of T over the last 5 years, we typically get 75 to 80% response rates, which is significantly higher than the aggregate. And I really think it's both the contribution of the program, the site directors, but it's the protected time and the follow-up that gets us that response rate. So I think it's possible to do, but you really need to have it on protected time.
We are, so it is the point that was made about sort of, we continue to do this, the data mounts, you know, it grows in size. And so I think that in coming years, you will have only larger and larger, even if in spite of the low response rates and the imperfect matching, there will be larger data sets to work with this. We're looking at as well, as we kind of think about the continuous renewal of the way that we do the FMLS, is to talk with the departments of family medicine about having this data managed centrally. Right now, each department of family medicine runs the survey by themselves, and they then send the data on to us. And it has these limitations associated with it, then that we are sort of having to do these probabilistic linkages later on. Some schools, you know, have reached out saying, this is really onerous doing this survey, you know, can you help us out here? And so we will be talking with the departments of family medicine as to whether or not, you know, they would have us, you know, with all the right security measures and confidentiality measures in place, and in discussion with departments of family medicine of what that would look like. But that could hold some promise, you know, in the future for having a data set that is a little bit more seamlessly kind of linked. Wonder if there are other questions, other thoughts.
Lorelei just put in the chat that programs are able to add up to 10 questions of their own. And Milena has done quite a bit of work at our institution in sort of asking about the pandemic and its impact on our trainees. And that's led to a lot of interesting scholarship. I don't know if you want to briefly talk about that, Milena, or where that work has gone.
Yeah, I guess I would just start off by saying that, Lorelei, you probably have the info. I'm not sure that each school is taking full advantage of this. It is a bit of work because you do need to apply for REB for your additional questions as an amendment to the existing REB at each institution to administer the survey. However, it's an amazing opportunity because this vehicle exists, the survey exists, it's not starting from scratch. You've kind of got a built-in system. So I would encourage everyone to think about, you know, if you've got questions either as the program leadership or as someone at a site that would really like to pair with the program or approach the leadership to say, hey, I'd love to know this, can we work together? We sort of had a very broad consultation process early on about what are we going to include in these extra questions that were allowed. And we sort of, what we found works best, because you get these sort of nominally 10 extra questions, was to have no more than 3 content areas that you might want to query. So for instance, we had early on asked about, R3 training. So what was motivating that? What were people choosing to do? We actually did an enhanced demographics questions. So we asked more about, family of origin and some socioeconomic demographics around that. In addition to what the college asks, we asked about core days and what people were finding valuable. But really what I think was really, really interesting and helpful was to use the survey. We really quickly able to pivot in the spring of 2020 to use the survey to query pandemic response and residents' perception of everything from mental health, professional identity, and skill acquisition. And we've continued to ask about that. So unfortunately, because the pandemic has lasted so long, so we actually have some really good data. We also were able to embed a question that we did some qualitative work. So by using the survey, we embedded a question when we were asking about COVID that simply asked if they were willing to be contacted. And so that was its own question, and that took them to a different page that they would then enter their email for contact. So it was still anonymized, but that allowed us to capture people that were interested in being interviewed. So we've conducted longitudinally about just under 25 interviews with people around their experience during the pandemic, again, around well-being and professional identity formation and disruptions, around redeployment, et cetera. So it again, without that vehicle, and this of course had really nothing specifically to do with CCFP, but we were able to use the survey to really do additional work that I think was important to do. And we had this built-in structure. So I think people should really think about how they can take advantage of this by working with the PI at your site, and certainly with the program at your site to think about what are the questions that are really going to be valuable for you and your institution.
It's such a good point, Milena. And I just would refer people back to a link that Laura Lee put in the chat here to the EERU website, where you will find our national report of the FMLS. You will be blown away by the breadth of data that is in this survey. It can tackle many, many questions. We've seen a nice cut of how it has been used to look at maternity care, but chronic disease management, mental health care, hospital-based care, ER work, hospital inpatient work, Indigenous health. There's many, many areas of practice, comprehensive primary care that you can use this data for. So I would encourage you to take a look at that and contact us. There's been comments too about just reaching out to us. We are totally here to talk with you about it. Elena, I see your hand up, and welcome your question.
Yeah, thank you. Just a practical question. So how do the residents actually receive the survey? Is it through their postgraduate program directors? Is that the person who disseminates it? Or do they just receive it directly from the college?
Maybe if I could ask Laura Lee, I see your hand up there, Laura Lee, if you would like to just...
Each program has decided locally what process and who is responsible. Some programs, the program director sends it. Some programs, the chair sends it. Some programs, PGME assigns an administrator. So the program, gets the documentation and decides locally how and who will be distributing the survey to their residents for each of the
Okay, so that's, yeah. I was just asking because I think that idea of having protected time could really change things around. And I just wondered how to, maximize the chances that people know that this is happening. I have never received, I'm not a program director, but I have actually never been aware that the survey was actually going out in September or at the end of the PGY2 year.
So what worked well?
Okay.
Let's go ahead.
We do have a sort of some intel on how different departments do it, and Elena would be happy to connect with people to sort of what is the secret sauce for getting a better response rate. Yeah, please feel free to get in touch with us. Ivy.
Locally is going to then the top down from the chair or from the college. If people receive emails from their own program assistant, administrator, or director, it's much, much better.
Great. Thanks. Just a heads up that, I mean, this survey was going out as early as 2010. And so we've got a decade worth of learners that have gone through, right? But now with the Outcomes of Training project, the opportunity as you're looking through here is we're in a process of creating what's the next version. So this next version will need to be ready by 2027. And Karen Grant is on the call today, and she will be helping to do this review process. But we would also welcome from all of you your thoughts about what could be added, what could be different. What are some of the other options that we can use in terms of administration or distribution of the survey as well, and also people who would be interested in actually a smaller group interested in actually really sitting down and looking at the survey directly. It will be utilized again. As I said, we need to have something ready for 2027. So we're going to be looking at the next 3 years of actually designing, testing, prototyping, and then getting it ready for full utilization. So just to put that out there, that we're in a renewal stage, looking for opportunities for new voices as well to help us.
Thanks so much, Ivy. It's yeah, we absolutely welcome that input, and Laura Lee has given a link there. Sarah, I know we're down to the last couple minutes here, but please jump in.
Thanks, Steve. For those of you I don't know, I'm the program director of Astor Family Medicine. And so you've asked about using the data. We use the data. We look at it on a regular basis through our continuous improvement committee, but we haven't had a great way of doing that sort of trend data look. Like, you know, we receive the report sort of individually, right, each time. And so we haven't actually developed a good local mechanism around sort of, you know, how do we sort of, yeah, how do we look at, do we create our own database to sort of pull that stuff into, or what's the right strategy? And so I'm kind of curious, just learning from other people about, are typically trend reports coming, like people asking for that trend data from you, or are there programs that are actually creating something locally to sort of, or asking to receive that data set in a slightly different way in order to generate our own database? I'm just kind of curious about learning from other people's experience on that front.
It's such a good question, Sarah. We do have a trends report up on our website. Again, you will see but it's national in scope. We can do this for you. I would, before you would lift a finger to start working with the data that we've sent to you, please just get back in touch with us, and we're happy to crunch the numbers and do sort of the analysis at our end. To the extent that we're able to do that, we are happy to do that for you and with you. But it absolutely would be that trend. We are seeing some very interesting trends, and Lisa had referred to some of that earlier as well. Again, there's a contact email in there. I just want to note we are coming up to our last minute here, and I know it's a Friday afternoon. I don't want to keep anybody longer than they wish to. The team will, I think, be available to linger on if people want to stick around and talk to the EERU team. I do want to thank sincere thanks to our panelists today who have really got us off to an amazing launch. We hope to do more of this. So some of it will be FMLS data. We have other really, really rich data sets at the CFPC, and we would love to share that with you, and we'll start to get the word out. I want to thank you for coming, joining us today as well. This was a fantastic turnout for a Friday afternoon of our first launch. Please feel free to get the word out, as we will keep you looped into future sessions, and it would be great to get the word out there, because I think there's a lot of power in data. Who said? I think Laura Lee, we had the Minister of Health with us earlier this week. He said data saves lives, and it was a powerful comment, and one that if you really trace it, it is probably true. And we would love to work with you and with the use of the FMLS data and other data sets. So please feel free to get in touch with us at any time. Thank you again so much, panelists. Thank you to everyone for turning out today. We're going to stick around. I'm going to linger on here. I know the EERU team is, perhaps our panelists as well. And I'll just look for other questions if there are other questions.
Yeah, we're going to order those T-shirts, Data Save Lives.